Welcome to our next video of heart failure. In this video, we'll discuss about the Framingham criteria and the management of heart failure. So, coming to the Framingham criteria, this criteria is used to diagnose the heart failure. And in this, the major symptoms includes first one, dyspnea. Dyspnea means difficulty in breathing. Orthopnea means difficulty in breathing in supine position, and paroxysmal nocturnal dyspnea. This is the first criteria or the first part of the major symptoms, and second one would be acute pulmonary edema, or third one would be rails and the S3 heart sound. And it also includes, this criteria also includes JVP, that is elevated JVP or jugular venous pressure, and abdomino-jugular reflex. And this abdomino-jugular reflex mainly occurs whenever there is a problem in the right side of the ventricle. And coming to the next, cardiomegaly means increase in the size of the heart. So these constitutes the Framingham criteria, which is mainly useful for the diagnosis of heart failure. Coming to the management of the heart failure with reduced ejection fraction, as we have discussed what is reduced ejection fraction, what is preserved ejection fraction, what is mid-range ejection fraction in our previous video. If you haven't watched that video, just go to my YouTube channel and it will be available. So coming to, in this part, we'll discuss about management of heart failure with reduced ejection fraction. What is reduced ejection fraction? Whenever the ejection fraction is less than 40%. So in this, there are mainly 4 classes of drugs are mainly used in managing the patient with reduced ejection fraction. So in this, the first part is we will block the sympathetic nervous system. SNS means sympathetic nervous system. Sympathetic nervous system is mainly responsible for the increased heart rate and increased force of contraction. So we'll give the sympathetic nervous system blockers in order to block these increased heart rate and increased force of contraction. As a result, the heart rate will be decreased and force of contraction is also being decreased. And these class mainly involves the main classes of drugs like beta blockers. We all know beta blockers, there are cardioselective beta blockers and non-selective beta blockers, but here we will use cardioselective beta blockers. In this, metoprolol, carvedilol, bisoprolol. The bisoprolol dose, we have to start at a very low doses. The beta blocker should be started at a lower doses, that is around 1.25 mg, and it can also be increased up to 10 mg. So these beta blockers mainly causes decrease in the heart rate and force of contraction. And the main point that you should remember is, whenever you are starting the patient with beta blockers for management of heart failure with reduced ejection fraction, you should remember the patient should not have any edema. Means there should not be any swellings. If the patient is having any ankle swelling, or the patient is having any anasarca, then you should definitely have to avoid beta blockers in that patient. If the patient does not have any edema, then only you should start beta blockers in that patient. And second class of drugs which we will use in this patient is for blocking the RAS system, that is renin angiotensin aldosterone system. Blocker should be given, and this mainly involves ARNI. ARNI means angiotensin 2 receptor blocker plus neprilysin inhibitor. So this is ARNI, full form is angiotensin 2 receptor blocker plus neprilysin inhibitor. The example for this is valsartan, which is an angiotensin 2 receptor blocker, and neprilysin inhibitor is sacubitril. This is one of the wonderful drug which is used for the treatment of the heart failure patients. And these class of drugs, ARNI should be given. ARNI is always preferred when compared with AC inhibitors, and AC inhibitors always preferred when compared with ARB blockers. So coming to the second class of drugs which we will use is blocking the RAS system. RAS system is mainly responsible for maintaining the high blood pressure and increased heart rate. So for this controlling of these things, we will use RAS, that is ARNI blockers we will be using. ARNI, angiotensin 2 receptor blocker with neprilysin inhibitor. Coming to the third class of drugs which are used are mineralocorticoid receptor antagonists. What are these mineralocorticoid receptor antagonists? There are spironolactone, eplerenone, and finerenone. These are also used. Spironolactone is also used for the treatment of resistant hypertension. Whenever the patient is having resistant, that is, whenever the patient is having blood pressure above 140/90, even after giving 2 drugs, even after the patient is on 2 drugs, including one diuretic, if the patient blood pressure is not controlled, then that is called as resistant hypertension. For this resistant hypertension, we'll use a drug called spironolactone. So in these heart failure patients, we will also give mineralocorticoid receptor antagonists. These are spironolactone, eplerenone, and finerenone. But the side effects of these drugs are hyperkalemia and gynecomastia. Hyperkalemia means increase in the calcium levels, and gynecomastia means there is nothing but the breast protuberance which is seen in males, which is called gynecomastia. So these are third class of drugs. And coming to the fourth class of drugs, are these are SGLT2 antagonists. SGLT2, what are SGLT2 antagonists? These are dapagliflozin and empagliflozin. And these two drugs are wonderful drugs which mainly used in treatment of heart failure, along if the patient is having heart failure and diabetes mellitus. If the patient is having heart failure and diabetes mellitus, for such kind of patients, these drugs are excellent drugs because they produce natriuresis, because they causes excretion of sodium, and they also cause excretion of water from the body, and without any causing, without tachycardia. So this is one of the main feature which are seen with SGLT2 antagonists. And the mortality benefits are most commonly seen. Initially with beta blockers, followed by angiotensin 2 receptor blocker with neprilysin inhibitor, followed by mineralocorticoid receptor antagonists, followed by hydralazine plus nitrates. So these are mortality benefits forever. For any patient, we have to start initially with beta blockers. These beta blockers are the highest, these are the first important drugs which will prevent mortality in a patient of heart failure. Second group of drugs is ARNI, angiotensin 2 receptor blocker along with neprilysin inhibitor, and third one will be mineralocorticoid receptor antagonist. The final drugs are hydralazine plus nitrate. And thank you for this class.